Yes, so we are going to have exciting moments to discuss the intersectionality between HIV and cervical cancer. I'm sure those who are especially in the health docket could be seeing this and could also be asking questions even at the community level. And to this afternoon, we have a great resource to discuss this. This session is hosted by National Cancer Institute, and we have the CEO here, Professor Meli, and there's amongst the key speakers with us this afternoon. My name is Okoro Dan. I'll be moderating this session on behalf of the team, and we look forward to having interactive sessions. So take notes, your questions, and then subsequently we'll have opportunity to respond to the questions. So, by and large, I believe all of us quite aware of HIV, the burden, and many a times also we have had discussions or overview of what cervical cancer does, especially amongst the women, amongst the leading killers of women, other than the breast cancer. And this has been in the lips, in the hearts of many people. And even the government, the ministry, is taking note of the burden of the non-communicable disease. As we age, as the economy grows, the infectious, the communicable diseases tend to go down, but the non-communicable diseases tend to rise, and this stretch our system. But good enough to know that there is prevention, there is management, there's something that we can do, and therefore, in terms of controlling the cervical cancer. Without much ado, let me take this opportunity to invite Professor Meli to give his remarks and session opens. Thank you.
Well, ladies and gentlemen, good afternoon. Did you enjoy your lunch? I would really wish to invite you to this session moderated by National Cancer Institute of Kenya. I've been introduced. My name is Elias Meli, just in case someone did not get it right. And I'm happy to see all of you seated here. Thank you very much. We are honored to have all of you as our guests this afternoon. We have a serious topic to prosecute and dispense by the end of 2 hours that we are allocated for this session. Feel valued. Know that we really appreciate for you to choose to attend this meeting. It means you have a question that you would wish answered. There is some gap in information that you would wish to know, and we are here to capacitate you this afternoon. We have a team that is going to enable us appreciate, HIV, HPV, and cervical cancer. The topic began in the mid-morning before lunch session, and our able lady from Nyandarua National Polytechnic began this discussion. And I was very happy to know that even when it is not the institute mandated with implementing the cancer agenda in this country, it is a topic that it's of great concern to all of us. So thank you very much for finding time to be with us. Now, I know the reason why we are here, as our moderator, Dr. Okoro, has mentioned, there is an epidemiological shift from communicable to non-communicable diseases. If I may ask, I am a teacher, I'm a researcher, and I take care of patients. And I like asking questions when I'm teaching. So just know that this session is going to be interactive. It's after lunch. I know right now the brain has moved to the tummy. You know what that means? That all the oxygen is now around your digestive system, so that there is less oxygen going to the brain, and there is a temptation to rest your eyes after lunch. But I'm praying that that temptation is not sent your way by the devil, because you need to be quite attentive. By the end of this session, you want to go home different than when you came in because of new knowledge, new information. Yeah, we are directly or indirectly affected by cancer. Before I speak about cervical cancer, HIV, HPV, the session we have for today, can I see by show of hands someone who has never been affected by cancer? Never. Does that mean all of us have interacted with cancer directly or indirectly? Can I see by show of hands those who are in affirmative? So most of us actually have been affected. And we are not worried about as much HIV as it is as with cancer now. It is quite a challenge that if you are to ask the devil, please send me one disease, how many would choose cancer to be sent their way? You know, it's the devil that brings diseases. Is that true? That is what the Bible guides. But we know that we have our role to play also in preventing diseases in general for us to be healthy, and we have a role to prevent diseases specifically. So there is an epidemiological shift now from, malaria, HIV, TB, because most of those over decades have been a challenge that we have had strategies to mitigate that, which have actually worked. Because hardly does someone die from TB now. Hardly does someone die from HIV. I know we mentioned in the morning that we still have around 50 people who die daily from HIV, but we have more that die from cancer in general, and more that die from cervical cancer specifically. Now, I would wish to talk more about cancer in general before we talk about cervical cancer, HPV, HIV. What is the intersection between these three, and how do we approach jointly and commonly? If I may ask, can someone share light moments, define, as many of us are working in, what cancer is? Let me hear from us. Who is that who will go first to define to this meeting what cancer is in your own words? You don't have to be a medical doctor, you don't have to be a healthcare worker. You can use the language that you understand most, as we have people settling down. We have, and in the second row.
Yes, cancer is uncontrolled multiplication of the body cells.
Uncontrolled multiplication of the body cells. Very good. Someone to add into that? We have a gentleman at the fourth row, far end.
When the cells become malicious.
When you respond, mention your name so that we can recognize you
Joseph.
and where you come from.
Joseph Ongado from Nyandaro County. Workshop AYP. Yeah.
Go ahead.
Cancer is when the cells become malicious and
when the cells become malicious,
yes,
and they multiply.
Yes.
Any other addition to that? We are all building. There's a lady.
Good afternoon.
Good afternoon.
Maybe to add on what they have said, I would say abnormal cells.
Abnormal cells. So we have uncontrolled multiplication of cells. We have malicious multiplication of cells. We have abnormal cells multiplying. Any other final one? Let this one be the last one.
To add on that, they destroy the body's tissues.
They destroy the body tissues. We have a young lady at the second row. She denies being young, but she is.
I wanted to say almost the same thing, that just the way you've summarized and the way my fellow members have summarized. Uncontrollable, now they come and as they multiply, just as you said. Now the worst part of it, now when they come in, they multiply uncontrollably. Now they will come and destroy the body tissues. So I just now that they have said what I wanted to say, I've decided to summarize it.
Thank you very
bring all
much for
things
giving us
together.
an executive summary. So cancer is this disease that begins with a genetic mutation. There has to be some changes in our genes that then enables these cells to multiply uncontrollably, excessively, and has the capacity to spread from one site to another site. And I think what you have, contributed into this definition is all correct. So there has to be some changes at the DNA. That is the smallest particle in our bodies. And when this discussion will be continuing this afternoon, you will see how HPV plays a role in causing some changes at our genetic level that then makes these cells around the cervix to multiply. And the wording is excessive and it cannot be controlled. So it is important for us to define what cancer is. And it's the same for all types of cancers. It's also important to mention that cancer is not one disease. It is not like HIV. I know HIV also has a lot of different, uniqueness in itself, but we do not have one bullet for cancer. Cancer is one disease in, more than 200 diseases. Cancer is like, presenting with headache, but there are many causes of headache. In this case, we have cancer of the skin, cancer of the bone, cancer of the blood, cancer of the cervix. Mention every little cell in your body, cancer can begin from them. And the approach, the causation is different. The approach to treatment might be very specifically different, but generally it could be the same. There are two cells in our bodies that cannot be affected by cancer. Which ones are those? Two cells in our bodies that cancer cannot affect completely. There's a hand behind.
Hello, I'm Naomi. Hair and nail. Hair and nail.
Hair and nail. Can we clap for her? You guys are very brilliant and you guys are reading. So it is only the hair and the nails that cannot be affected by cancer. But every other cell in your body, potentially, cancer can begin from it. And one unfortunate thing with cancer is its carcinogenesis, the process of causation of cancer. From when you get exposed to a risk factor like HPV that we'll be handling this afternoon, to when it actually manifests itself, this cell should have multiplied 1 billion times for you to see in a microscope that there is a change that is then cancer. Can you imagine 1 billion? That is not little money if you are discussing cash, right? Now, for you to see a speck of it in a microscope, this is a process that is extremely slow, and sometimes it takes up to 5 to 10 years before you present with symptoms. That is what we call subclinical phase. Now, National Cancer Institute of Kenya is here this afternoon presenting this session. How many of us know what National Cancer Institute of Kenya is and what it does? Can I see hands up? Oh my goodness. I think I should just talk about NCI here. We should not even be discussing about HPV and the intersection with cervical cancer and HIV. So briefly, just to bring you home, most of us have our caps and don't live here without a cap. That is going to brand. By the time you are leaving this building, this room this afternoon, you are part of us fully. But for you to understand what NCI does, this is a state corporation. It is a parastatal. It is a saga. semi-autonomous government agency, just like NSDCC or previously NAC, which is under Ministry of Health. And we were established in 2012 under the Act of Parliament, Cancer Prevention and Control, number 15. We've been in existence for more than 10 years, and we are here to strategically, position ourselves to achieve one mandate which this institute was established for: cancer prevention and control. And we want to focus more on prevention, but unfortunately, because of many challenges that exist, we find ourselves doing a lot of work in controlling. And controlling means, early diagnosis through screening. We will talk about HPV screening here shortly, all the way to when unfortunately you get diagnosed and you must go through treatment, then you must be able to get quality treatment. And our function number one is advisory to the Cabinet Secretary, health on matters on priority interventions in cancer prevention and control. We are also charged with a mandate to make sure that there are centers across the country that are able to diagnose and treat cancer. We are also charged with a mandate to make sure there is adequate human resource to address, our cancer challenges in the country through, building capacity formally and informally, and I would like to mention here, because I know we also have people living with HIV here. We have people who have been doing a lot of work in the community through the community health programs. We are integrating cancer in also through the community health promoters to make sure that informally there is messaging that gets to the people at mashinani. As much as we would want to train top-notch oncologists like myself and others who are here, including Dr. Anissa, who is one of our speakers this afternoon, we want to make sure there is capacity at all levels. That is one of the functions that National Cancer Institute of Kenya has in this country, and we are part of the entire ecosystem of healthcare in the country. We also have another role, which is cancer research. And for us to have answer many questions that we have, the only pathway is conducting research, which can either be clinical research or non-clinical research. It is important to mention here that we have been treating a lot of our patients using foreign data. And unfortunately, just like when HIV began, late 80s, early 90s, a lot of our treatments were based on foreign data. But over time, there have been a lot of clinical research conducted in the country that solved our local challenges. We are following the same pathway with cancer currently to make sure that we originate our own data by our own people that then will respond to the challenge that we have. I will surprise you that we may sometimes be over-treating or under-treating our patients because we are using data generated from people who are biologically different from us. I had mentioned earlier on that cancer is a genetic problem at the beginning, and it becomes a systemic disease when it spreads in the body. And it further causes socioeconomic challenges because it is one disease that I always equated to terrorism. And that is why the approach cannot only be through Ministry of Health. We were created so that we become semi-autonomous to be able also to use a multi-sectoral approach, where then we can engage where our risk factors are, which is in the environment. How many of us are farmers here? I am one of them. How many of us are farmers? How many chemicals do we interact with on a daily basis? As much as we will be talking about HIV this afternoon, remember causation of cancer is factorial. It is not one thing that if you were asked today, what is this one thing that I should do right? You remember this guy in the Bible who met Jesus and told him, I have done everything right. Right? You know that guy? I have, supported, I have even, paid my tithe offering, and he was told one thing, go do what? Go sell what you have. And it was very difficult, right? So there is that one thing that if today you ask me, Daktari, you are an oncologist of long-term experience practicing treating patients. You've gone through training, locally, regionally, and internationally. You must be having so much experience. Give us the answer. Up to now, I will give you what are risk factors and few areas that we've established causation. One thing with cancer, if there are people here who have conducted research, there's something called association and causation. There is so much association that we know about cancer, but there are very few that we know they directly cause cancer. And HPV that we will be discussing this afternoon is one of those and a few others. So we have a mandate to make sure that we conduct local research to answer our own questions so that we can advise the government pretty well on its interventions. I think to that point, probably we have an idea. We play a very big role in advocacy, to make sure there is access and affordability, there is availability of quality interventions, whether it is treatment using, chemotherapy, radiotherapy, or any other systemic treatment, including surgery, which is a very key, modality of treatment. So we also have this huge mandate of creating awareness, public education. And we are regulating that space of cancer to make sure that it's only quality across the entire continuum of care. What I'm doing right now is creating awareness about National Cancer Institute, its mandate and its functions. And we are a body that has, board of trustees and the CEO leading management and staff. We are based at Landmark Building, Landmark Plaza. We are actually in the same building with National Syndemic Disease Control Council. And no wonder we are here in this Maisha Conference together, because we move as one team. Our approaches to our, challenges are pretty much, we have some areas where we converge and we have some areas where we diverge based on the challenges that we have. So specifically, let me bring you to my presentation for this afternoon. I do believe I've created enough awareness about National Cancer Institute. Are we feeling comfortable now that we are dealing with an institute that has, a very special mandate? Can I hear whether that is true or no? Do you agree that National Cancer Institute of Kenya has a special task to deliver to the citizens of this country? So wherever you are, when you leave this place, you be our ambassadors so that you can direct people to know where they can be assisted. That is why I decided to take these 15 minutes to create that awareness amongst ourselves. So to my presentation for this afternoon, I'm going to scare you a little bit. And my duty, someone mentioned, I think it was Dr. One of the panelists in the mid-morning session, that in health, unfortunately, we scare people than encouraging them so that they can be part of the process. What scares us is when we are also real with you to discuss the burden of, cancer in this country. And quickly, what scares us is figures. When you know that a lot of us are being diagnosed with cancer, more often than not, there are people who are quite silent about their health challenges. It is only us who have this mandate to coordinate everything about cancer in this country that then we collect data across board. Patients who are diagnosed and even programs which are involved so that we are able to coordinate everyone. Now in 2020, 10 million deaths occurred due to cancer worldwide. 10 million. That is like a quarter of Kenya wiped out by cancer globally. Now in Kenya, this is the second leading cause of non-communicable deaths. The leading cause is cardiopulmonary diseases, heart and lung problems. But I think with very complete inputting of data, you will be surprised that cancer is underreported big time, and it may actually be the leading cause of non-communicable, deaths. And as we streamline our work, we will certainly give you much reliable data as we move forward. This is the third leading cause of cancer. This is the third leading cause of death in our country. We still have communicable diseases, the infections of this world, which includes malaria, TB, and HIV. And annually, cancer mortality increased by 16% from 2012 to 2018. This then informs you that the burden of cancer is growing on a daily basis. So we are at risk on every day being diagnosed with cancer. And specifically, the latest statistics, this was 2018, every day in our country, every year in our country, we have more than 42,000 people diagnosed every year. And we have 27,000 of those dying. Those of us who are quick in mathematics, what percentage is that? What percentage is that? Can someone calculate quickly? 27 of 42,000? More than 60%, actually almost 70% of those who are diagnosed with cancer on daily basis die by the end of 1 year. If we are in this room and we are 100 of us, every year, 70 of us would not be in this world because of cancer. Isn't that a huge burden that requires, intentional support and strategies to reduce this burden in our country? What socioeconomic effects does it have? The impact it has in our country is the high cost of treatment is there. And these people who are diagnosed with cancer, either complications of treatment or the disease itself, would not allow them to contribute to our economy. We lose a lot of hours, man hours that would be very useful for their families and also for this country, for some of us who are working. And unfortunately, we even end up losing life. That is quite a loss. You'd rather be sick and have controlled disease like most patients living with HIV are. They are able to function, they are able to work, they are able to take care of their families. But unfortunately with cancer, we find ourselves losing lives. UHC, to cushion catastrophic out-of-pocket expenditure. We are all awake to the fact that our country is streamlining health delivered in this country through universal health coverage. You saw yesterday, there were bills which Ministry of Health is now proposing to repeal the NHIF Act so that we can have more coverage from NHIF towards UHC. And one of them is primary healthcare bill or fund. So it's important for us to know that our country is also intentional in this. This should then ideally include holistic cancer care. We have our voice in UHC, and it is important to bring to us that we are actually advocating for those who are diagnosed with cancer within the country. Now, global cervical cancer statistics. If I look at this meeting room, majority of us are ladies. And that is pretty much because of the interest. As much as there are men, we know in our lives, we have our women, we have our spouses, we have our daughters, we have our mothers, our grandmothers. So it's also of interest for all of us to be here. A large majority of global burden occurs in less developed regions, where it accounts for almost 12% of all female cancers, with 604,237 women diagnosed with invasive cervical cancer globally as per data in 2020. Those women are our relatives. Those women are our fellow Kenyans. They are in developed countries. It is us. And high-risk regions with estimated age standardized rates over 30 per 100 include Eastern Africa, where we find ourselves, Southern and Middle Africa, and generally these are in low middle income countries. And cervical cancer remains the most common cancer in women in our region, and over 80% cases in LMIC countries, especially Sub-Saharan Africa, Kenya included. It is a serious matter that it should scare all of us. More importantly, the leadership, because where there is good leadership and governance, then definitely there is going to be service delivery. And the National Cancer Institute has that responsibility. So bring it home. Cancer in Kenya, and cervical cancer specifically. So cancer is the third leading cause of death in cancer, as mentioned earlier on. There is a rising trend, and cervical cancer, what we are discussing today, earlier on I mentioned that it's never one disease, and HPV plays a very big role. I would want you to look at, paragraph number 4, 99.7 cases linked to HPV infection transmitted through sexual contact. I think this is where we need to discuss. This is where we have actually intersectionality between HPV and HIV in terms of transmission. It is sexually transmitted. We had a whole mid-morning to discuss about prevention using condom programming and programs. And someone mentioned, and I'm happy to see our dear lady from Nyandarua County, she's here with us. Thank you for bringing this topic in that session, and we are at it now. Second most frequent cancer among women aged between 15 and 44. Can I see the ladies who are aged between 15 and 44 here? Can I see them? Can I see them? Tom, don't raise your hand. Okay, so we have majority of us here, more than 90%, we are in that category, and we are at risk of being diagnosed with cervical cancer. I will not ask the second question of how many of us are sexually active, because that is controversial, right? Allow me not to ask that, but I've asked silently. Just know if you are sexually active, you are at risk. But then, how should we then approach this? Because it's a basic need, as we agreed in the morning session. It is part of life. It's part of growing up. Now, this is the leading cause of deaths in Kenya, aggregated. Whether you are discussing cancer of the brain, cancer of the lung or the liver, cervical cancer causes more deaths in this country than any other disease. And that is why, as much as we are considering all types of cancers, we have to address this one specifically, because it's one disease that actually it's possible to treat with curative intention. It is one disease that we can prevent. And shortly, in my next slide, is elimination of cervical cancer. We've been given a very simple and easy strategy that all of us should know. I am here training us to be advocates. I mentioned earlier on when I was inviting you to this afternoon session that we have a formula WHO has called on every country which is a signatory to WHO, Kenya being one of them, to make sure that we use this approach of 90-70-90, a call to action to eliminate cervical cancer. What does that mean? It means we have to vaccinate 90% of our girls by the time they are 15 years. How many of us have daughters here? Do we have daughters? Do we also have sons? Are they also at risk? We will know how our sons are at risk. But now let's mention about for elimination of cervical cancer, because our sons do not have a cervix. Ama wako nayo? I remember one time someone was being asked, you've seen this NTV, random asked in the street and someone was asked, what is a spine? People have different ways of, defining what a spine is. So I wouldn't be surprised that people may not even know where the cervix is. It is this little structure that connects the uterus to your external genitalia. That is the entrance to the uterus. That is where the cervix is. And we mentioned that HPV, interacts with your cervix through sexual contact, because it is the men that transmits HPV. Unlike HIV, that is cross-transmission, that you can contact HIV from either your sexual partner. HPV, if you want women not to be diagnosed with HPV in this world, then eliminate all the men. That can be an easy strategy, right? Should we eliminate all the men? Should we? Well, now without the men, where will the ladies be? So that one is I don't want to go into this discussion. Please spare me this one, all right? Yeah, please spare me this one. I know there are people who are willing to pursue it, but I'm sorry, I will not continue. So what we are being asked is 90% of our daughters at 15 should be vaccinated, with HPV. And I know I did ask how many of us have daughters. How many of us have had our daughters vaccinated with HPV? How many? The hands were so many that had daughters, but those ones who have had their girls vaccinated are now a drop in the sea. They are older. I've talked of 15. At 15. But let me give you an exit window. We can extend as long as they are not sexually active. If they've not had any sexual debut and they are 17, they are 20, they can still benefit from the vaccination. Just keep your questions, note them. I know Dr. Anissa is here. She will answer most of those questions when her time will be here. Okay? So now, if we vaccinate our girls by 15, and we begin at 9 years, so don't wait until the 14th year for you to rush into vaccination. 9, 10, because we have appreciated that sexual debut amongst our children has come down. Initially we told children are 18 years, but we've seen girls who are pregnant at 10, 11 years. So then we have brought down, the limit for vaccination to take care of those. We are alive to the fact that there are a lot of changes. There is a lot of cultural changes now in our environment. Now, the second strategy is 70% of all our women, by the time you are 45 years, should have had cervical cancer screening. Whether you are using HPV screening or you are using VIA, villi screening. Again, how many of us ladies who are here have had screening for cervical cancer? Good job. You guys are doing well. And how many people have you shared with to be screened for cervical cancer? Very many. You are doing very well. You are doing our work. Thank you. I'm going to reward each one of you when you will be leaving here. All right? Let us continue with the messaging, because it is what will actually allow us to be diagnosed. Unfortunately, if you have already had the disease beginning early, and when you get treated when you are diagnosed early, the outcomes are very good with very limited, toxicities, which then means there's a lot of organ preservation and you can continue with your reproductive life. But when the disease is diagnosed when it's advanced, then you end up, unfortunately, sometimes losing your uterus, losing, your ovaries, and also, your entire reproductive system is affected. And remember, these are people who are before 45 years. These are people who would still want to have children. I have unfortunately seen a 20-year-old lose her entire uterus. That means that, lineage is cut. It is quite sad, it's unfortunate, but it has happened. For a disease that we can completely prevent and eliminate out of this world, the third strategy is those who are diagnosed with either precancerous, because this is one disease that does not begin as cancer. It begins as pre. And if you don't address it at that time, then it progresses to cancer, what we call invasive cancer. But before that, it is non-malignant, that you can sometimes treat with just freezing those cells, exposing them to high temperatures, or just doing a slit using some electrocutical mechanism, and you just kill those cells. If you do that, then you remain with all your organs intact, and most importantly, you have your life to take care of what God has planned for you until you exit this planet. So this is the 90, 70, 90. So those who are screened and they are found to have lesions, whether it's cancer or not cancer, 90% of them should be treated. And we are not putting 100% because one thing that we appreciate with cancer is there are patients who have not been exposed to HPV completely, but they still develop cancer. I did mention that 99.7% of cervical cancers are caused by HPV. There is still a 0.3% that are not HPV related. It is important to mention that in statistics, we always conduct our studies with a 95% confidence interval. What does that mean? There is a 5% chance that your conclusion might be wrong. But then you have 95% confidence that what you have concluded is correct. So it's important to mention that. So while you will be leaving this meeting this afternoon, just know that we can eliminate this cancer. It is quite sad and unfortunate, as much as we have many of us here who've been screened for cervical cancer, but in our country, if you saw the KDHS data that was released a month ago, 16% of our women have undergone cervical cancer screening. So it's important for us to know, as much as most of us here have, let us do more to sensitize all, because I know you are leaders from whatever capacities you are in, whether it is through your support groups for the HIV programs, support groups for cancer specifically, we actually are doing badly. Australia is the first country that is likely to meet this target before 2030. But there is hope. We still have 7 years to do this. And if we are going to put our strategies, which are NCI-led, which are community-oriented, trust me, 7 years is a lot of time for us if we have the resources and we have the goodwill and we have a cultural shift for us to appreciate that this is a disease that can be eliminated. So we have HIV as a risk factor of cancer. Because of time, allow me to summarize this way. HIV infection is a major risk factor for cervical cancer. How? This is a key driver of high cervical cancer burden in sub-Saharan Africa. There is a lot to do with our compromised immunity in any cancer causation. And that is why, if you look at the approaches for treating cancer in general in this country, we are now shifting into, modulating our immunity so that if you are exposed to any risk factor, and that's what vaccination does for our girls, it actually primes our immunity so that when you engage HPV, then your immunity is strong enough and it can fight and overcome cervical cancer and you reduce the risk. So immunity, when it's compromised, and HIV has done that a lot, we have other HIV-related malignancies, not only cervical cancer. We also have lymphomas, which is a cancer that originates from the lymph glands. If I know Mombasa is hot and most of us are not dressed, like how we would dress in Nairobi now, if you are in your sleeveless ladies or you are in a vest in your room in the evening, if you touch your armpits, these are where the glands are mainly. All of us have glands. They play a very big role in our immunity, but when cancer cells begins from them, then those glands will swell. Just like whenever you have an infection, you would see a gland in your groin area when you have a wound or an infection in your leg. That is not cancer when you have an infection. Let me not confuse. I wouldn't want you to be worried that when I see any gland anywhere, I have cancer. That is not what I've said. But I'm just using that as an analogy that sometimes when you have a lot of your glands popping up everywhere, they could be a problem and cancer might be one of them. So then go to the hospital so that you are assisted to confirm whether it's that one or not. This is also HIV related. We also have anal cancers. And anal cancers also has an association with HPV. I know Museveni the other day took a very serious action in Uganda, but we live in a very liberal world that people are choosing what they want to do, what they think is right to them, and sometimes we may not have any control about that. And it is a reality. So for us in health, we also play a big role in advocating for those who are in minority groups because their health is a priority to us. And if they have a risk factor, we need to prevent. And if they have a disease, we will treat them irrespective of what choices you've made with regard to your social life and status. So that is also another, HIV-related malignancy. We have something called Kaposi sarcoma. This is a skin cancer that you would see someone, and if some of us here have been diagnosed and have gone through cancer treatment, or you've been in clinics, you may have seen fellow patients who have, swollen legs, and you wonder what's going on. Someone had normal legs, but suddenly someone has a leg one-sided more often that is as huge as a leg of an elephant. It is because this is a type of cancer that blocks circulation of fluids in your system, so the legs swell. That is also HIV related. We have many that conducting research might fit this criteria and this category. So when we have increased risk of HIV being, we have HIV driving our compromised immunity. I will show you that if you're HIV positive, you have 6 times risk of being diagnosed with cervical cancer. So if we have some of us who are living with HIV here, and they are being exposed to HPV, you are likely to be diagnosed with cancer, and your risk is 6 times compared to someone who is HIV negative. Are you seeing how it's very important that if we address the HIV problem, we will also address the burden of cervical cancer and HPV infection that is going to be quite a challenge to us. So what integration and innovative approaches do we need to use in this case? So we have to make sure that we have we invest a lot in information. We need to know what is current. We need to know what is likely to happen in future. We have to make sure that we conduct screening. We have to make sure that we target, cancer prevention among women living with HIV. And we have to integrate multi-sectoral, women-centered care approach as recommended by WHO. And we must make sure there is community engagement, accessible screening, vaccination, and treatment of what is likely to address the cancer problem. Key focus, we must appraise cervical cancer situation in Kenya. We must measure the impact and progress towards it. We must, whatever you've done, it must be measured. The SMART objectives that we all know. If at all we have any intervention, any approaches, it must be measured for us to know whether we are working or not, or we are investing in vain. We have to reflect on the progress towards 2030 elimination targets. We have to share experience in cervical cancer elimination in the context of HIV, and we have to explore innovative strategies for prevention and control. We have to foster partnerships for collaborative engagement. We have to develop a plan for ending cervical cancer in Kenya by 2030 geared towards global elimination targets. And I know in this building, other than having people who are Kenyans, you are all stakeholders in the work that we are doing at the National Cancer Institute of Kenya. You could be a patient, you could be a teacher, you could be, a leader of whatever capacity you are. You could be a partner that has been supporting a lot of activities in HIV space. And here we are creating sensitization that you also have a role that for your, there is another session going on in another breakout session discussing about aging in people living with HIV. All right? We have people now living with HIV as old as 60, 70 years. They have controlled their disease. That is no longer their problem. But now they are faced with all these challenges, which cancer is a big one. Generally being, age being a risk factor because of your immunity, which is dwindling, and now HIV makes it even worse. So we have to think together how jointly, collaboratively, cooperatively, we are going to, address this problem. So that is my last slide, that NCI's Kenya's journey of ending cervical cancer by 2030 geared towards global elimination target standards as a beacon of hope and progress, leading the way towards a healthier future for this country. Thank you very much for listening to me. I do appreciate it. I'll be happy to take any questions later.
Have we not been educated? You now feel more learned. Our next speaker, thanks a lot, Dr. Meli, the CEO of National Cancer Institute. Not only have we learned about the cancer, but also what NCI deals with. And our next speaker is Dr. Anissa. Dr. Anissa is a gyne-oncologist practicing here in Mombasa at the Aga Khan Hospital. And so she'll be speaking to us, giving us a few highlights, some of which have already been related to by Dr. Meli. So karibu sana, Dr. Anissa.
Good afternoon. How is everyone? Are we still awake? Back there? Are we there? Good to see you. Thank you so much for coming for this. It's always a great honor to be able to speak about the things I do, the things that I've dedicated my life to. As you've heard, I am a gynecologic oncologist. Big words that just mean that I'm a specialist in women's cancers. So any cancer that's related to the genital tract of the female, I'm the woman to see. All right? So as I wait for my slides to be pulled up, I'm really grateful to Professor Meli. He's literally done my job for me. He's said pretty much everything that I want to say. And so I'm just going to summarize and highlight a few areas. Okay, so you can all see that? Is this too loud? Okay. All right. So my mandate today is to talk about cervical cancer prevention. As we are all here, we rely on you to go out there and also help us in managing us to help in cervical cancer elimination. You've heard about the WHO goals, which we'll get into it in a bit, but the whole point is we are all in it together. Be you male, be you female, you have a role to play. And Dr. Meli talked about the cervix. The men in the room, please put up your hands. All the men in your room, just put up your hands. Those who know where the cervix is, let your hand remain up. Na washuku wengine wenu. So this is a brief schematic on what the cervix is. And when you look at it, that is where the female genital tract should be, ideally, all right? And so I don't know if my cursor could work. No, it does not. So you can see, I'm going to move here a bit. Okay, so I'm back. So that's the part, it's literally what we call the doorway to life. When women are in labor, all the time you have a finger being inserted into your genital area, being told, Mami, tunangalia ka njia imefunguka. That's the njia, that's the cervix. That's the one that has to dilate for the baby to come out, and that's the part that gets affected with HPV and results in cervical cancer. All right, so now we are all on the same page. Very good. So Prof. Meli has already talked about this. The reason we are gathered here today is because cervical cancer is the leading cause of cancer-related deaths amongst women. We have 3,286 women dying every year, and this number is the one that we know of. There are so many more women out there who are not able to come to hospital, who we probably are not captured in this. So if we were to estimate, I'd say this number is about over 5,000. Because the number of cases we see in our clinics, it's just too crazy. And so when you look at this map, when you see the dark blue areas, those are the areas that have a high incidence of cervical cancer. One thing you note about them is it's the sub-Saharan Africa, the poor countries, what we call the developing countries, third world countries. We're stricken by poverty, and already we're still having more problems with cervical cancer. And of course, it will follow that the same areas that have high incidence of cervical cancer has a high rate of death from cervical cancer. And then when you interpose the HIV map on it, you can see again, sub-Saharan Africa, Kenya, we're right in the middle of it. We have a high incidence of, or prevalence of HIV. And as Prof. Meli has talked about, these two kind of work together. And that's why we are here today, because we know there's a correlation, an association between HIV, HPV, and cervical cancer. And that's why we're here today. For me, as a student of anatomy, the cervix has been one of those unsung heroes of the body. It's one of those organs that are in there quietly working. It has its own immunity system that infections will come, it will work so hard and fight off the infection. Most of the time, a woman will not even know they have an infection because the cervix is that good. It will fight it, get rid of the infection, and you continue on with your life without knowing what has happened. And so because of this, when women get HPV infection, and most women will get HPV, it's one of the commonest sexually transmitted infection, as you've been told. So with your good immune system, without HIV, without immune compromise, most women are able to fight off the infection and proceed on with their life without a problem. And this has been evidenced. I think the light is messing the slides a little bit. But the thing is, when we look at slides, tissues that we've taken from patients who have cervical cancer, we find that there's a lot of immune cells together with the cancer cells and the normal cells, which show us that this cervix has really been working to fight this infection. But now the problem is when HIV comes in, the immune cells are busy fighting the HIV, and the human papillomavirus, the HPV, is able to hide and evade the mechanisms of the immune mechanisms, and that's when the infection persists, and that's when people develop cervical cancer. So when you talk about the human papillomavirus, it's a very tiny virus. We'll not go into the virology of it, but we have to understand where we're going by looking back. And so I'm going to give you a little story over the years. Back in 1886, a guy called Sir John Williams, he was the first person to describe a lesion in the cervix, which to the current scientists, we call it carcinoma in situ, meaning there's just a bit of cancer in a small area in the cervix in this particular case. And for the better part of the late 1800s, the early 1900s, it was referred as epidermoid carcinoma. For scientists, this means a whole different thing, and meaning the treatment can be different, it can cause other problems, and meaning it was just not well understood. It wasn't until 1920 when someone called George Papanicolaou, a Greek man who had migrated to the US, when he started looking at the cells of the female genital tract, comparing the normal cells with the abnormal cells. And he was so excited as to seeing this kind of abnormal cellular mechanisms that he actually, in 1932, he went and presented his studies in a conference such as this. He was laughed off stage. First of all, he had a terrible accent because his English was terrible. He was Greek, so he did not speak English very well. Secondly, it was such a foreign concept that people didn't even believe in his science. And so they thought, you know what, it's not good enough. And it wasn't until 1939 that by his work of scraping the cervix with a piece of glass, this is how far we've come. With a piece of glass rod, he would scrap the cervix to be able to get the cells, to be able to look at them through a microscope and determine which one is healthy, which one is unhealthy, which one has cancer, and which one has not. Now, while George was doing all this, in the Belgian Congo, that's when we identified the first HIV-1 case. And of course, all the way through that, up to 1981, now there was a confirmation of HIV infections with linkage to AIDS, which at the time, it really blew people's mind that people are dying out of this mysterious disease. And that's when it was linked. While people are busy with HIV, in Germany, Dr. Harald Zurhausen, who just died a couple of months ago, he was able to identify HPV-16 and HPV-18 and link them to cervical cancer, to the point that he actually realized that there was a connection between a virus and cancer. And for the first time ever, in 1985, the New York Times advertised that for the first time, papillomavirus has been linked to cancer. Dr. Harold said, you know what, if we've been able to see there's a virus, that it causes cancer, we can actually manufacture a vaccine to help protect against this virus. But again, he was laughed off stage, and people thought, you know what, that science can never exist. Little did he know he was like 20 years before his time. And for sure, in Australia, back in 1990s, Professor Ian and Professor Jian started studying the HPV virus and made a vaccine out of it. Are you seeing how far we've come? And there's still more ways to go. So when we're talking about the HPV virus, it is a DNA virus, and just like I have a name, you have a name. We've also named these viruses, but we give them numbers, and we divide them into two main groups. We have a high-risk group and a low-risk group. This essentially means that for those who have a high-risk kind of virus, they have a higher risk of developing cervical cancer, while those who have a low-risk virus, they can develop HPV-associated illnesses but are not cancerous. Do you guys know genital warts? Ugly, right? They look terrible, and someone would think it's cancerous, but it's not, and they can't become cancerous. But they're caused by type 6 and 11, which are benign viruses. When we talked about HPV being the commonest sexually transmitted infection, this is what I mean. If I have, I'm sorry, I'm going to use the front row. These are the perils of sitting in the front row. If I have 5 ladies, do you mind standing up for me? These 5 ladies. She's asleep. Do you mind standing up for us? And I'm only using this as illustration. I have 5 ladies, beautiful ladies standing in front of me. I'll have the last one sit down. In the grand scheme of things, if I was going to look at how many women get HPV, these 4 ladies would have HPV and only 1 not. That's how common it is. Kindly take a seat. I'm not saying that they have. I'm just using for illustration. Please take a seat. All right. 4 out of 5 women at a time will have HPV. In a woman's lifetime, she has an 85% chance of contracting HPV. And the men, I'm not leaving you behind. Yours is even worse. You have a 92% chance in your lifetime of developing HPV virus. And so most of us, you'll get the virus, you'll clear it, no problem. But then there are other issues which I'll discuss in a bit that will make us understand why there's some people who develop the cancer and those who do not. For adolescents, it's even worse. Because of their biology, meaning their anatomy, it's not well formed. Their immune system, it's not well formed. These adolescents who have an early sexual debut, then they have a higher risk within the first year of their life, they have up to an 80% chance of contracting HPV and developing cervical cancer. The youngest girl I've had to manage was 16, and she had a stage 3 cervical cancer. So her life was just messed up because of an early age of sexual debut. She was active at 11 years. And these are the things we need to fight against. So a bit of science, just brief, how it comes about. So once the HPV has been introduced into the woman's genital tract, it realizes, it's a smart virus, by the way. Sometimes I can't help but admire it. It is so smart that it knows it can't survive on its own. So it immediately dashes down to the bottom of the cervix, to the very low layer, which is called the basement membrane. And from there now, it starts replicating, it starts developing, it starts spreading itself, multiplying, and releasing itself outside to now go up to the vagina until we replicate the process. And so this way, by diving down into the basement membrane, it's able to evade the immune system. So you have the immune cells that are just scouting around. We said the cervix has its own immune system. So we have these immune cells just scatting around, looking for any infection. But the HPV, it has hidden. Sort of reminds me of a lion in the grassland savanna. It just hides underneath the grasses and then attacks. Exactly, that's HPV for you. So a bit of comparison between HPV and HIV, because I realize sometimes people confuse these two, as Donald Trump showed us recently in the media. Both are sexually transmitted, okay? Both are. HIV requires body fluids. HPV requires touch, okay? That's the main difference. And that is why, as much as we love and I appreciate that we were talking about condoms early in the morning and the use of how it prevents HIV. It can prevent HIV, and if you're preventing HIV, then your risk of HPV can be lower. But the condom, unfortunately, cannot protect against HPV. The reason is when, I am assuming most of people here are sexually active, there are a lot of surfaces that are involved during intercourse. And so from the mouth to around the genitalia, the vulva, all of that is involved, and it cannot be covered by a condom. And that's why it's important to use a condom to protect against HIV, so that inadvertently you can also protect against HPV. And essentially, when it comes to HPV, as much as it's a sexually transmitted infection, you have no signs, you have no symptoms, you will not know when you have it. But HIV, when you get it, you get really, really sick. So those are some of the key differences about this too. And so to understand how this virus comes about, how cancer comes about, I'll tell you a story. I love stories. I was a history student. So for anyone who's discussing about cervical cancer, the name Henrietta Lacks will almost always come about. And I would really recommend, for those who love movies or love reading books, go look up a movie called The Immortal Life of Henrietta Lacks. It's a book, it's a movie starring Oprah Winfrey. Very good, very informative. Henrietta Lacks was born in 1920, born in poverty in the US when blacks were not considered as human. There was a lot of racial discrimination, so she was born in poverty. By the time she was 4 years old, she started working in a tobacco field. By the time she was 14, she gave birth to her first child. And between the time she was 14 years and 30 years, she had been treated for syphilis because her husband, Dan, had way with the ladies, if you know what I mean. And she had never received any screen for cervical cancer because, remember, she was born in 1920. And what was George Papanicolaou doing in 1920? He was creating the pap smear. So these things were not there at the time. And of course, as I said, she lived in abject poverty. By the time she was 30 years, she gave birth to her 5th child. And after she delivered, she had severe postpartum hemorrhage, almost lost her life. But she was patched up, sent off home. But then 4 months later, she was diagnosed with cervical cancer, and it took her life at the very young age of 31. So you can imagine what this kind of cancer can do to you. And so to help us put this story of Henrietta Lacks together, I put up this cartoon. And so if you're going to think about what is going to happen. If we start at the beginning, we've talked about early sexual debut, which Henrietta had, right? She started having intercourse when she was about 13 years, basically, all right? Grand multiparity, that means having many children. Many children means more than 2, essentially. So how many children did she have? 5. And then smoking, she worked in a tobacco field. Part of the harvesting of tobacco, you have to burn it and you inhale all these fumes. So she was smoking by second hand, technically. Then low immunity, she'd been treated for syphilis several times and other STIs. She had no cervical cancer screening. By virtue of her partner, she had multiple sexual partners. And then, of course, we've talked about STDs. And of course, now she ended up with cancer. So we know these risk factors. We know what is causing all this. So what are we going to do to be able to move from point A, take all this information all the way up so that we can achieve what Prof. Menli was talking about, elimination of cervical cancer? And WHO has started it out for us. We've been called to action. And I'm not going to go through this again. We've already talked about 90%. Let me see if you guys remember. Were you listening? 90% of girls, the more Kenya is up there. 90% of girls should be? Very good. 70% of women should be? By a high performance test. We'll talk about what that means right now. And 90% of women should be treated. Be it a precancerous lesion, be it the actual cancer, you need to have been treated. And so the whole goal of this is so that by the time we are reaching 2030, we have fewer than 4 in 100,000 women who have cervical cancer. But Kenya, where are we at? Right now, we are at 45 out of 100,000 women who are being diagnosed with cervical cancer. So 2030, we still have a lot to do to get there. And that's what we have, some of the things that we have available to us. The HPV vaccine, we've talked about vaccination of our girls. Right now we have 2 major vaccines that are available, the Gardasil 9 and the Gardasil 4. The Gardasil 4 is available to the public, to girls, free of charge. And when it comes to who is going to get vaccinated, and according to Kenyan guidelines, all girls between 9 and 15 years should be vaccinated free of charge. But don't let the boys behind. Don't leave the boys behind. Also, boys can be vaccinated. Because of some specific issues, the vaccine is being offered free to girls, but boys have to buy. So boys can still be vaccinated. So if you have a boy like myself, you can still get them vaccinated, and I have. All right. So usually the recommendation was at least 2 doses, but for anyone who's HIV positive or any immune compromise, they need to get 3 doses. The first one, then a month after, then 6 months after. That's because the immunity is just not working. So you have to give them more. And so the Kenya KEPI schedule, the vaccination schedule, has incorporated HPV as one of the required vaccination doses. But recently we have found that through different studies, and I'm actually proud to talk about this paper by our very own Nelly Mugo, where they've talked about, it's called the Kenshi trial, where girls who have received just 1 vaccine, they've been shown to have immunity for up to 10 years. And that is pretty amazing. Because we saw that when we started vaccinating people, there was an uptake in the first dose, but for the second dose, less than half would show up. But we've seen that even that 1 dose can make a difference. And so please get the girls vaccinated, because it has been shown that more than 90% of HPV attributable cancers have been prevented. And when you talk about HPV attributable cancers, do you know which ones I'm talking about apart from cervical cancer? Prof. Melly talked about some. Tell me. Any shout? Anal cancers, nasopharyngeal cancers, meaning in the mouth and the throat. You have vulvar cancer. The vulva is the external part of the woman's genital tract. We have penile cancers. So men, HPV is a problem to you too. It's only that we can't screen you. But men can get penile cancers. So all of this, as well as those ugly genital tracts, genital warts, can be prevented by this HPV vaccine. And a study done in the US tried to look at different races to see if it's just maybe the white people or just the black, and it was shown both whites, both black, also the Hispanics. You can see the trend is downwards. When you're given the vaccine, the infection rate with these organisms as well as development of this precancerous lesion goes down by over 65%. And so one thing I want to be clear is that there are other prevention strategies and not just vaccination. And we've known that our young girls, our young boys, they're having sex at a very early age. So we have to educate them. We have to talk to them about their bodies. Women, we need to tell our girls what menstrual cycle is, what parts of their bodies are. There's some women who don't even know where the cervix is. And you need to start explaining to them as early as possible so that they can understand even issues of consent or issues of examining themselves to be able to be sure they know what is happening and seek help as early as possible. And of course, lifestyle changes like smoking. Smoking, the main problem is that even if you smoked, say, in your teenage and you smoked chronically, then you stopped, those effects can still manifest 20 years later in the cervix. They cause irreversible changes in the cervix. So smoking, they should not even start at all. So please, let's talk to our young ones as early as possible. And so those are our key takeaways. HPV vaccine, very important. Single dose can be used. The Prof. Meli had mentioned this, the naivety of having not been exposed, meaning that you've not initiated sexual debut, then it makes your body respond better to the vaccine. And that's why we try to vaccinate girls before they start sexual debut. To finish up, we're talking about screening, and we said a high performance test. Right now, the key recommendation by WHO is screening by HPV testing. It is available in most centers, and you can do it as a physician can collect the sample, or the woman. You can walk in and tell them, Apana, I don't want anyone touching my privates. Give me the brush, I will go to the bathroom, collect the sample myself. It is just as effective, if not better. So women, you can collect the sample yourself. You don't have to be afraid of the speculum. Isn't that good news? Then why aren't you clapping? Clap! So anyway, so now for the HIV infected individuals, because of the virus and the low immunity, we find these women, they have and this even Meli said, they have a 7 times higher risk of developing HPV infection, precancerous lesion, and cervical cancer. So for those who are HIV positive, they have to be screened more often. All right? So one of the key messages that I want to take, when you get out of here, whenever you find a woman you're in conversation, please just ask them, have you had your regular cervical cancer screening? Doctors out there, a woman comes to you, she has a flu, whatnot, treat her flu. Then ask her, have you had your cervical cancer screening? Please, let's be advocates. Let's educate people out there. And as Meli also talked about the Australian example, and funny enough, I'm sharing that. They actually had, do you remember my first slide? How many women died from cervical cancer in Kenya per year? 3,000? In Australia in 2019, only 239 died of cervical cancer. Imagine that. So it's preventable and it's very easy to treat if we catch it early. And so, and for those unfortunately who have cancer already, the key message is they need to get the right therapy at the right time. So to summarize the key points, let's vaccinate our young girls, let's educate the youth, let's encourage women to undergo screening and regular checkup, and please, let's do science, let's research, and let us trust the science that we are actually doing research on. And hopefully, we can continue this work, and whichever obstacles we meet, we'll be able to overcome them. It might feel like we're walking on a tightrope, but there is hope, and we can achieve anything that we set our minds to. Thank you so much for your attention.
Mwenye masikio? Mwenye masikio? Na macho? Yes, now this room is highly concentrated. Tough things, great things, isn't it? And all the ladies say? Okay. And this, they are not, it looks like they are still wondering whether they are at 90 or they are 70 or wamerudi 90. Prof. I know. Prof, so I don't want to go back to school. But just here first.
Dr. Anissa, very, very, very good presentation. Eh? There's somewhere I saw hormonal contraceptives for 10 years and you zipped by it, and I was wondering whether that was a typo. What was that about? And then also, just to throw it out there, that I hope we'll have the same progress with Epstein-Barr virus, which causes Parkinson's lymphoma, which is also another problem.
Somehow my spirit was telling me that that question will come, but there it is. But I thought there was going to be a time for it, so probably in another session, but just respond to that.
In deference to Prof. Ndwati, you were also my teacher, so I bow down. So, well, yes, unfortunately, and this is not to scare women away from contraception. It has been shown that when women use the combined contraceptive pills, you know, the daily pills, when you take 21 days, then you stay 7 days, and take another 21 days, the continuous use, and this is, mark my words, continuous use through to 10 years, it causes changes in the cervical mucosa, changes in the ability of the cell to function properly, and it makes the cervix more prone to developing HPV and the infection persisting. So they are at a higher risk of persistence of the HPV, and when the HPV persists, it becomes cervical cancer. That's it. Oh, which method is safer? Excellent question. It all depends on the woman's desires. If you want an implant, it's also good. For those who want the injection, I don't like it very much, but you can get the 3-monthly injection, or you can put in a coil. You can stay with a coil for up to 10, 15 years, and it is very, very good. All right. Thank you.
And I know have the media here, so that may be the headline. But so our next speaker, thank you. Our next speaker. No, let's hold on a bit. Let's hold on a bit. We have just 2 presenters. Please, I know that you are burning. Please, can we just tolerate just a bit? We want to hear from a survivor. Let's give a chance. But before then, let's hear the roadmap. What is the ministry? You have heard of where those graphs that Anissa was showing, where is Kenya? And what is the Kenya doing? What is the ministry? What is NCI doing to tilt or to increase to achieve that 90, 70, 90? Okay? Then you hear from a survivor. All right? And Anissa will be back with that kind of interactive presentation. Just close off. Few minutes, please. Truth. Can hear people are burning here with the questions. Thank you.
Okay, good afternoon, everyone. Yes, my name is Ruth Muya, and I work for the National Cancer Institute of Kenya. I lead the Cancer Prevention and Control Directorate. I'm very happy to be here to share with you what the National Cancer Institute of Kenya is doing to tilt the graph. I know you are damn scared. After having been shown, you know the anatomy, the pathophysiology, and the damage that HPV is doing. And I know the last statement was even more scary. Now that we have our appeals, we are wondering, are we trying to expose ourselves to cervical cancer? We are responding to this situation, and we have come up with a roadmap towards elimination of cervical cancer in Kenya. And this is what I am disseminating. It's a policy document. So my presentation outline, I will go through the introduction, rationale, why we developed the roadmap, the process, and the roadmap objectives, implementation framework, and then we summarize. I'll be very fast because most of the items have already been shared. So, of course, we've already been educated and sensitized that cervical cancer contributes to about 12% of all cancers diagnosed in Kenya, and it's the leading cause of cancer deaths in the country with over 3,200 deaths in the year 2020, and 9 women die every single day as a result of cancer in Kenya. 9 women, so within about 2-3 hours, a woman has just passed on. We've been here for about how many hours? About an hour or so. Perhaps in the next 1 hour, a woman will just pass on. So it is a serious situation in Kenya. And sadly, we are saying the uptake of screening remains very low. According to the KDHS 2014, uptake of screening services among women in Kenya was 16%. And 10 years almost, over 7 years later, 2022, the uptake was 17%. So behavior has not changed even over a decade. We are not taking up the screening. The main cause of cervical cancer, we've already been told, and I know we struggle to explain where the cervix is. There it is. And therefore, WHO called for action in the year 2018, requested or asked all the countries to eliminate cervical cancer within the century. That is by the year 2030. And we are saying we are on a countdown. Looking at the instances of cervical cancer in Kenya, we can see it's the second most common cancer in the country, after breast cancer. And then looking at the deaths, just to repeat again, losing over 3,000 women per year. This is Kenya, and therefore it's the leading cause of death in women. And the causes of cervical cancer, we've already been told, HPV linked to 99.7% of cervical cancer cases. And we've also been educated on the high-risk types of cervical cancer. Can you remember them? High risk. Which one and which one? Number what and what? Perfect. You are really keeping up with the discussion. We've also been taught cervical cancer or HPV lesions take so long. They are silent. That's why we are saying silent killers. We want to tame those silent killers. A normal cervix, once infected with cervical cancer, can clear to a very big extent, over 80%. And some 20% progress to precancerous lesions. So that's what is picked during screening. And then a few of them also are able to progress to full-blown cancers. The risky factors, in a nutshell, describing, summarizing. Early initiation of sexual activity, having multiple sexual partners, having a sexual partner with multiple sexual partners, co-infection with other sexually transmitted infections, immunosuppression or presence of HIV, mortality, tobacco use. That is in a nutshell what cervical cancer is. Why were we developing the roadmap? Again, the statistics are there and we have high numbers of cervical cancer. That is one of the reasons why we are developing the roadmap. Yet cervical cancer is one of the cancers that can be managed successfully if detected early. Effective and the cost-efficient measures exist for not just managing cervical cancer, but eradicating the disease altogether. Kenya is yet to implement the measures at scale. We know what is causing the cancer. We know the most cost-effective methods of even eliminating it, but we are yet to decide whether we can even want to eliminate. That's why we came up with the roadmap. Science has reviewed a 3-legged or silver bullet to eliminating cervical cancer, and we're calling it triple intervention. And we've been taken through the 3 components. That is the magic bullet. Vaccination or primary prevention, early detection, and the proper management of the disease. We are yet to decide whether we want to do it. A bit of science, as into why HPV vaccination helps is because of what we've been taken through. Those graphs are presenting, the life course approach to cervical cancer prevention and control and why the 3 interventions. Between 9 years and 15 years, we can do primary intervention through vaccination. That's why we are targeting the boys and the girls. I was talking to very young people on our booth outside there, and they were wondering why we're talking about cancers, because they are too young to talk about cancers. And at some point, we were able to agree the behaviors that they are exhibiting right now will give them high chances of developing cervical cancer, like tobacco use and all, sexual irresponsibility, among others. We're also focusing on secondary prevention and tertiary prevention. Secondary prevention, just around 30 years. Remember, we've explained how cervical cancer behaves or how HPV progresses to precancerous lesions. So it can even take 10 years before it starts changing the cervix. And that's why we want to screen women, between 25 years and 49 years again. I have worked in the cancer space since the year 2000, and I have buried girls 18 years old with cervical cancer. So yes, cervical cancer can be gotten quite early depending on one's immune situation. The other rationale, another item why we are developing the roadmap is that WHO developed implementation framework to guide countries towards elimination of cervical cancer by the year 2030. So the World Health Organization already did their part, but we are yet to adapt. And this was 2018. Today is how many years down the line? 5 years down the line. We are yet to adapt them, guide us. The need to have a country-specific roadmap that aligns the local context and the guide implementation towards achieving elimination targets of the 90, 70, 90. This is the song we are going to sing, 90, 70, 90. You see it many times, and we already explained what that then means. And the roadmap for elimination of cervical cancer in Kenya sets out priorities, targets, and actions for the next decade that will move the country towards this goal. The process was participatory. Stakeholders were engaged. Cancer experts, academia, researchers, faith sector, civil society, community partners, county and the national government were involved in the development of this roadmap. We got technical support from the UNFPA, and they also supported the team to develop these financially, thanks to UNFPA. So the specific objectives of the roadmap is to scale up HPV vaccination, expand coverage and access to screening, diagnostic management of precancerous lesions, and treatment palliative care. The other objective, the last one, there are only three, to strengthen the capacity for monitoring and evaluation of cervical cancer prevention and control. And our implementation framework is presented as a matrix that has key outputs, expected results, strategic action, performance indicators, and even an area for looking at the baseline, and then targets. And we are saying it's countdown to the year 2030 towards elimination of this monster, the silent killer, cervical cancer. So we are checking ourselves midterm 2026, and finally confirming what we've been able to achieve by the year 2030. So part of the outputs of what we want to look at, there are actually about just two outputs. Increase HPV vaccination for all girls, age 15 years by the year 2020. Expected result area one is to have the 90% HPV vaccination coverage by the year 2020. And we have set, targets for the mean evaluation and then the end evaluation. The second strategic action on that item is to increase uptake of HPV vaccine, awareness and acceptability of the HPV vaccine, and the reporting of the vaccination uptake. And the targets, countdown to the year 2030 is, in the year 2022, we were at 33%. So we are making good progress. We are hoping in the year 2026, we will be at 60%, and the end of the countdown will achieve our target. Output two, I said there are only two outputs, is increased screening for women of eligible age from the current 17 to 70%. So I don't know what miracle we are going to do to get ourselves from 17% to 70%. You will be telling us by the end of the presentation. And so our strategic action or the magic that we want to use is increasing level of awareness from the 45% to 90%. So currently the level of awareness just people getting to say they have ever heard about cervical cancer is at 45%. But as more study that we did in the UHC pilot counties, that was Machakos, Isiolo, Nyeri, and the Kisumu, we found that level of awareness, 45% is just ever having heard about cervical cancer. But as to whether they understand what causes it and what they need to do, that level of knowledge was less than 10%. So the level of knowledge is wanting, and the comprehensive knowledge to initiate action or to trigger action. So we still have some work to do to educate, not just having heard about it is one thing, but having understood that there's something you can do to prevent it or to eliminate it is a different thing. So integrate cervical cancer screening into other similar services. While I worked in the reproductive health, where I served for not less than 15 years, cervical cancer screening was part of reproductive health interventions. Please take it back. Also for the HIV, strategic intervention, we want to increase screening, and we've really talked about that. Expand access to HPV testing in public health facilities from 2% to 90%. In the year 2022, only 2% of the facilities were able to provide HPV screening. And so the uptake is also very low. HPV testing. Let me repeat myself again. In the year 2022, only 2% of women were tested using HPV testing. Remember, we've been told we can now take our samples and have a DNA test other than the usual visual inspection with acetic acid and glucoside. So the new technique or the new approach to testing, the uptake is extremely low at 2%, and we want to go to 90%. So we can do better than that. We want to ensure availability of commodity supplies, equipment to get that done. We also intend to improve availability of laboratory services for cervical cancer diagnostic. There is one thing to be screened and people are able to visualize a pre-cancer lesion. And there is another thing to move forward and get confirmation whether you are dealing with overt cancers. And the turnaround time is not pleasant because the diagnostic services are unavailable. And only 9 counties in the year 2022 were able to, properly conduct diagnostic for cervical cancer. Institute screening programs in private and public institutions, the counties, ministries, department, agencies, and everyone. Wherever you work, you can institute screening program in the workplace and encourage innovative models for cancer screening, such as the telemedicine, mobile clinic, and the use of community health promoters for self-sampling. I'm almost there. I'm almost finishing. I want to link treatment to supportive care. 90% of women with the precancerous lesion needs to be linked to treatment and the care. One thing you realize is that once a woman is diagnosed with cervical cancer, and we are saying the road to even accessing the diagnosis is very long, then the turnaround time from the time they are diagnosed to the time they are started on treatment is another whole world. And when we started, we say the disease is spreading. And somebody said it is a very malicious kind of a spread. And then we are saying someone is diagnosed at Melt, Isiolo, or Tana River, and the diagnostic services are only available in Nairobi. And do they even know that there are such services that are available? And by the time they are diagnosed, because they also need to pay, perhaps the transport is a challenge and the money to pay for the diagnostic is a problem before they are put onto the treatment, which is also costly turnaround time. So you know what then that means. We also would want to disseminate and support implementation of cervical cancer treatment guidelines, protocols, and strengthen patient navigation through the continuum of care to reduce turnaround time, strengthen pathology services availability, expand surgical capacity, improve access to radiotherapy, chemotherapy, strengthen and integrate palliative care. By the way, 70% of cancer patients are diagnosed when it's too late, and very little can be done in this country. What that then means, they need to be put on supportive care, appreciating their quality of life, counting, their life days, not the days in their lives, strengthen and integrate palliative care and continuous capacity building, and we want to reduce stigma. We still are struggling with the stigma. And what are our next steps then? This is the second last slide. National dissemination of the roadmap. We have just begun. We want you to help us disseminate this roadmap, or even give us inputs to make it more friendly. Develop county-specific costed implementation plans for elimination of cervical cancer. Those are our next steps. They are almost our call for action. We also plan to reference on UHC agenda for cervical cancer elimination and support execution of the priority actions that we just mentioned. And to summarize finally, that we believe that 70-90 target is attainable, and it makes economic sense to invest in taming this silent killer. We all have a role to play, we've said that, and you can actually identify your role. And no one needs to come and tell you what your role is. You can play your role because you can identify it. So we are now counting down to 2030 towards elimination of cervical cancer. Do not wait. Cervical cancer is preventable. Thank you very much for listening.
Do not wait. Do not wait. Yes, so it gives me great pleasure to invite Grace Kamala as she comes. Yes, Grace Kamala, please come. The floor is yours as Prof will be shooting a question. And Grace is a survivor, and she will give her story on how. Zipporah, not Grace, Zipporah Kamala. Yes. Sorry.
Habari zenu. Poleni, nitatumia lugha ya Kiswahili, labda na lugha ya Kizungu mahali. Kwa majina yangu naitwa Zipporah Kalama, natoka Kilifi County, Ganze constituency. Nyimbo ile ya safari ya Bamba ni kesho, naona ni leo. I'm from Bamba. Niko hapa kama cancer survivor and HIV survivor. Nilikuwa diagnosed na HIV mwaka ule wa 2009. Ndio nilijua hali yangu ya virusi. Nikaanza madawa. I am a mother of 2 boys. Thank you. Ni mama wa watoto wawili wavulana. My first born is 28 years and my last born is 25 years. So niko mzee. But I don't look like mzee. Then 2019 ndio nikaanza matatizo, nikaanza kubleed sana. Ilikuwa siku ya Jumamosi, nikaenda kwa Sako, Imarika Sako pale Bamba. Then nikaanza kubleed. Nikableed ile sijawahi kubleed. Sasa hii niko 49 years. I'm bleeding to 50 years by deck. Sasa nikafikiria what is happening. Nikakimbia pale hospitali, mimi ni supportive staff pale hospitali, Bamba hospitali. Nimeshukuru leo kumuona Maria. Maria amekuwa supportive kwangu sana kwa kitengo cha HIV. So nimeshukuru kuingia hapa na kumuona Maria. Nikakimbia pale Bamba hospitali, nikawa referred pale Kilifi, nikafanywa CT scan, nikaambiwa ni labda ni uzee unaanza, early menopause. Lakini nilipolala that night bleeding ikaendelea. Then nikachukua hatua, nikakuja vipingo. Hapo ndio baba watoto alikuwa anaishi. Then akanambia turudi tena Kilifi ili tufanyiwe cervical cancer screening. Hakuna mahali nilichelewa because sikurudi tena Bamba. Nikachukua hatua, nikarudi tena Kilifi, nikafanyiwa cervical cancer screening. Na daktari akanambia pale kuwa ni cancer niko nayo, ningoje majibu. After 2 weeks approve kabisa. Then after approve akanirefer to Aga Khan kwa Dr. Riazi. I thanks Dr. Riazi. Pia nashukuru MCI kunialika hapa leo. It's because wamelink na Dr. Riazi pale Aga Khan ndio nimefika hapa leo. Nikaanza matibabu pale Aga Khan na Dr. Riazi. Nikiwa sasa ninaendelea kubleed, HB yangu ikashuka chini sana. 26. So nikafanyiwa transfusion, nikiwa hapa niko blood O negative, ile haipatikani. So nikakaa pale Aga Khan for over 2 weeks. Nikitafuta damu huku na huku, nikapata. Nashukuru Mungu alinisaidia nikapata damu. Nikawekwa damu, then daktari akanambia niko ready kuanza chemo pale. Nikaanza the first chemo pale Aga Khan, then second one, third one, then nika-develop side effects. Nika-develop numbness. Miguu ikashindwa kukanyaga, mikono ikashindwa kushika. Ukumbuke ni mwaka wa nini? Wa corona. That was COVID-19. Namshukuru Mungu kwa sababu aliniwezesha. Ninapenda jamii yangu sana na jamii yangu inanipenda. Si watoto wangu peke yake, the whole family at large. Kama uko hapa, ishi vizuri na jamii yako. That is very, very important. Aliyenisaidia mimi ni msichana wa dadangu aliolewa na jamaa. Huyo jamaa ndo alinibeba na gari yake tu Nairobi. Wakati wa COVID, wiki ile niende Nairobi ndio Riaza amenirifaa, ndio Uhuru akafunga njia kuenda Nairobi. Ndio mimi hapa Riaza ananiambia niende Nairobi for chemotherapy and radiotherapy. Lakini namshukuru Mungu kwa sababu huyu kijana aliniwezesha kama mamake na nikaingia Nairobi. Kuna hospitali pale karibu Mpisha kule Parklands ina deal na cancer peke yake. I was registered there. Nikaanza matibabu. Nikaanza chemo tena, nikaenda kwa CT scan tena. Nikaanza radio, 25 sessions of radio, nikapitia. Nikaanza tena sessions za chemo. Daktari akaniambia tunaanza upya. I was with Dr. Mbogo there. Nikaanza tena chemo upya. Sasa nikamaliza vizuri. Nikiwa pale tulikuwa watu wengi sana. Ile hospitali ni cancer center tu. Sasa niko pale, I have a very supportive sister of mine. Nafikiri wale wamenipokea leo wamepata niko naye pale. Amenileta mpaka hapa. I thanks God with that sister. Kwa sababu amekuwa supportive na mimi. Nimemove na yeye the whole journey. Mpaka leo amenambia huwezi enda hapo mahali peke yako. Nimekuwa na yeye mpaka nikaingia kwa conference hall. Ndio akarudi nyumbani. Basi nikaendelea vizuri tukiwa pale kwa foleni hivi. Wengine wanauliza ni nani hapa anaenda kwa chemo ama kwa radio? Nawaambia ni mimi. Yule dadangu wale wamemuona ni mslim. Wanafikiria labda ni yule dadangu. I thanks God kwa sababu siku lose weight, siku lose hata kilo moja. In fact vile nilikuwa nimeenda Nairobi, kule kuko na avocado, bamba hakuna. Sasa nikawa nakula fruits. Mimi nilikula fruits bwana. Nikapanda 22 kg. Sasa hii nimejaribu kujirudisha at least nikuwe 71 hapo. But that time, aliyeniona that time, I was 82. Vile niko short, 82 kg. BMI 36 and above. So namshukuru Mungu kwa sababu nilienda vizuri kule, matibabu yangu yakapita vizuri. Wenzangu tukiwa kwa chemo nikaona wenzangu wakitapika, nikaingiwa na hofu nyingi sana. Lakini namshukuru Mungu kwa sababu chemo ya Riazi sikutapika, chemo ya kule sikutapika mpaka nikamaliza. Nikamshukuru Mungu. Kitu ambacho kilinifanya labda niwe chini sana, labda ukiangalia mkono wangu hauko sawa. Due to my low HB, then nilianguka, kulinyesha, nikaanguka, then nikavunjika mkono. Nikaenda pale Nairobi, nikatengenezwa mkono, nikawekwa chuma kwa huu mkono. Nikiundergo all those treatments, niko na chuma kwa mkono, niko na POP nimefungwa, nikienda kwa radio. But I thanks God kwa sababu nimepita hiyo. Nikarudi Mombasa tena, niko vizuri. The only thing ni chemo is very expensive, radiotherapy is very expensive. Kabisa, lakini namshukuru Mungu kwa sababu aliniwezesha. Ile neema ilinibeba. Na nilikuwa naishi mbali na Nairobi with my sister. Tunatoka kule mpaka pale hospitali. Fare kila siku because radio ni kila siku. Only Saturday and Sunday ndio hufanyiwi chemo. Ndio hufanyiwi radio. But chemo it was weekly, once in a week. Sasa nashukuru Mungu kwa sababu nilipitia hizo hatua vizuri. Nilipofika huku nikapata some side effects za radio. Daktari akanambia niende kwa colonoscopy. Niko pale, daktari ananireview vizuri. Ninaendelea vizuri kwa sababu pia colonoscopy nimefanyiwa. Ninaendelea vizuri. Nilipatikana niko na cancer at stage 2. Na ninashukuru kwa sababu I am not meeting my visions. Nilikuwa ninaishi kwa boma, sasa hii niko kwangu. Nimejenga kwangu, niko kwangu na watoto wangu pale. Watoto wangu pale wamesoma. Sasa hii nashukuru, mmoja anashikilia bunduki huko wako. So I'm very proud of my kids. The other one yuko pale ni driver, the other one ni polisi. Wanafurahikia nikiwa nao pale. So nimesikia mafundisho yakisema pale unaweza kuprevent and you can be treated. Ikiwa imejulikana mapema. Pale hospitali surely nimepata kibarua sahihi. Nikiona mama hivi namwambia go and screen. Yaani sitaki hata stories za ati mimi tafadhali wale wako hapa. Pale OPD. Kama uko hapa na unaona wagonjwa pale OPD, saidia hao wa mama jamani. Usiklack tu umwandikie dawa aende na hujamwambia go for screening. Nimesema kuwa niko na HIV na niko na cancer. Surely HIV hainisumbui. Nikiwekewa hizo magonjwa mawili hapa. HIV nilikuwa mimi hata sioni kama ni ugonjwa surely. But nilikuja kuona cancer ndio ugonjwa kwa sababu ya pesa ile ambayo nimetumia. But with HIV, DTG moja tu every morning. What is that? Lakini leo hii ninakuja ni spend more than 40,000 because of one session of chemo. 40,000. Hiyo ni only one session of chemo. So, nimesema hizo vitu mbili mtu ukipewa uchague, mimi nachagua virusi tu. Virusi is nothing. So, ninashukuru, nimepewa only 15 minutes. Kwa hivyo mimi naweza ongea, lakini nashukuru, ninaendelea vizuri, watoto wangu wanaendelea vizuri, jamii yangu iko pale kunisupport. Kila hatua ninaenda. Nataka nimalizie kidogo japo mwenye nini anataka kuniambia niondoke. Ni juzi tu mwezi wa 6 nimepoteza mamangu. Mwezi wa 6 tu this year. Bado inanipain sana. Sasa katika zile picha alipigwa, CT scan akafanywa Said Fatma. Akiwa amekufa ndio majibu yanakuja, ninaambiwa mama alikuwa na kansa katika utumbo mdogo. The small intestine. Sasa nikafikiria wewe Mungu, mimi nimeishi 2019, amekuja tu ameenda. Hatujajua, tumejua ameenda. So it's good kufanya screening mapema. Ukisikia kitu si kawaida, chukua hatua. Thank you very much. Mungu awabariki sana.
Asante sana Zipora. Wow. Great moments. We pray that God sustains you because you trust Him and you believe and you are grateful for His grace. Now, time for maswali, and I would like to invite and I recognize the CEO, Dr. Ruth Maisha, from National Endemic Disease Control Council. And the CEO, Dr. Meli, had mentioned that they share the building, and that's why even the integration. And you have heard Zipora talking about how, actually she's even promoting integration. Okay, Clark mgonjwa hapo kwa outpatient, tumor screening. Okay? So, may I invite Dr. Meli, Dr. Anisa, Ruth, Grace. No, Zipora, sorry. I don't know why I'm in Grace. Hey, okay, sorry. Zipora, please. The floor is yours. And you've heard from the role of NCI, National Cancer Institute, Kenya, the issue what we have, the HPV 90-70-90, the roadmap, and we've got very illustrative on how the interconnection between HIV and cervical cancer. And to note that Kenya, we are not doing very well. We are yet to scale up. And while Maisha is talking about the triple threat, here we're also talking about the triple intervention. So there's some interconnection. So let me take this opportunity to, I know so many hands are going up, but I'd promise that Prof to start off.
Thank you very much. And Zipporah, thank you for sharing your story. We're grateful to God that you're here and can tell us that story. Eh? And I want to agree with you that the cost of treating cancer, the cost of treating cancer is very expensive. I supported my sister-in-law, and many years ago now, more than 20 years ago, every month, 20,000 shillings for the drugs, and then all those transport costs. Eh? But my question is to these my colleagues from the Ministry of Health. The Ministry of Health, I think, has about 16. When we're in the middle of the COVID pandemic, we had only 16 qualified pathologists. The core of diagnosing cancer requires a well-trained pathologist. And we have 16. It's the discipline of medicine which has the lowest training in specialists. 16 pathologists employed by the ministry, a few scattered others in the private sector. That's not a plan for eliminating cervical cancer, you know. And I didn't really hear what as NCI you're doing in terms of addressing that particular problem. And I was looking, this recent education report on universities, the costs going forward, this is what they're proposing, unless as a government you come and say, Awacha, your story. The cost of 1 year of training, of 1 year, MED is going to be 600,000 per year. And the training of a full pathologist is 5 years. The Arkan Hospital does a slightly different program where you train a pathologist who is just doing, say, pathological anatomy, another one is doing hematology, another one is doing whatever. But as a country, actually, we need the more comprehensive care because you're not going to be employing 2-3 pathologists in a hospital. If already right now we don't have enough. That to me is the big crisis, and it affects not just it's not affecting just people who are about cervical cancer, but any patient who actually needs pathological services. The second problem you have is this story of imaging. You know, your CT scans, your MRIs. You don't have enough radiologists to report. So but you have many the sonographers, the radiographers, they'll go and run. It's like a photo. See, it's like when you photograph wanafanya, but it doesn't get reported. But they also charge a lot of money for it, isn't it? An MRI is about 20K, right? And a CT scan is at least 10K. NHIF, I think you have to get authorization for this thing to be done. The basic salary of the basic daily monthly income, the average income of a Kenyan, regular Kenyan, if I'm not wrong, look at Ministry of Planning money, those things, it's about under 2,000 shillings. In rural Kenya, maybe in the urban areas is a little more. Right? That is a conversation we should be having. And I see now they've gone, NHIF is no longer there. They have some new things. We talk about this universal primary health care, universal health care. What does universal health care mean for somebody to get that diagnosis
and get treated? That to me is a question. When you say primary health care, what is primary health care in this context? And what is inpatient care? Or is it another scam to take 70% of NHIF payments? No, this is a very serious problem. Up to this day, up to today, 70% of NHIF payments are to private hospitals. Yet the majority of Kenyans getting health care go to a public hospital. And in fact, India, government of India, one of the streams of earning is money of people going for treatment in India. That's a question. Anyway.
Dr. Meli, uko na kazi. Let's be short.
Wow. Let me stand. My name is Steve. I work for National Syndemic Disease Control Council as a regional HIV coordinator. I'm working in Kisumu counties and Siaya County. Now, Dr. Meli, thank you so much for your wonderful presentation. But what I did not see is the demonstration of how the cervical cancer is spread in the country, because when you're dealing with diseases, it's important to know the geography or the populations that they are mostly affecting, so that we can focus our energies there and focus our resources there. We know that there is a relationship between the HPV and non-circumcising communities, like because you told about the issue of the foreskin and how it is likely to hide the HPV virus. Can that be demonstrated by your surveys? Is it documented anywhere in this country how cervical cancer is, the burden of cervical cancer? Because if this information does not come out, then our health education needs to be backed by data. And I think that's a gap that I've seen. So if you can do that for us, it will be very good. You also said, Dr. Anissa, you told us that 9 out of 47 counties are the ones which are having ability to test cervical cancer fully. Kindly tell us which are these 9 counties so that we know where the gaps are. Thank you.
Being managed in terms of time. Okay.
Okay. Yeah, good afternoon. My name is Esther. I wanted to find out because Dr. Anita, when you said that we are giving 2 doses of HPV vaccine to girls who are 10 years to 14 years, we give Cervarix at our facility, and it is for 10 years to 16 years is 2 doses, that is at 0 and at 6 months. And then again, after 16 years, we are giving the 3 doses, 0, 1 month, and 6 months. And in your conversation or slides, presentation, you say that those who are immunocompromised should get 3 doses. So I wanted to understand, is it the ones that are 10 years to 14 years, or is it every other population? Because now having 16 to and up to 49 at 3 doses. The other thing you said is about the boys should get a vaccine. Yes, they pay for it. I wanted to know what are the doses they get, what is the intervals, and what are the ages that they should receive. The last one is for Dr. Meli. You taught us that cancer does not affect the hair and the nail. Does it also affect the teeth? Or is there any other thing? Thank you.
Good afternoon. My name is Lucy from AHF Kenya. My question goes to Anissa, Dr. Anissa. You've said that the HPV rapid can be done or distributed to everybody. How much is that HPV? Because I remember I referred my clients to one of the hospital and she was charged between 6,000 to 8,000, and this is a low income client who cannot afford to pay the 6 to 8,000 shillings. Last year, I think Portrice and Likoni sub-county were doing a pilot projects on HPV, and I sent a client. She was not able to do the self-testing of HPV by herself. My other question goes to Ruth. I think there's something that needs to be done, especially on the turnaround time of the results. Our patients are dying at KNH because they cannot afford to go to, I think, something called Texas Cancer Center. They cannot afford radiotherapy or chemo at Texas. They need to be treated at KNH, but the queue is too long. Last, I think it was in June, I did an MDT to our client, PLHIV, who went to KNH, stayed for 3 months, and nothing was done to her. So is there anything that can be done? Because I know that we are a devolved country.
Last one.
Thank you very much. I'm Murithi Nchege from Tharaka Nithi County. I had a similar presentation in the morning on uptake. So my question is, one, in terms of diagnostic capacity, we have these molecular test engineers but machines, which we can rely on to do HPV testing. In each every county, we have like 3, but yet they don't have those modules. What is the plan? Because other counties already they have that. The other question I have, science has shown that HPV vaccination among even women who have already started having sex, like Australia, can reduce persistent HIV infection. Why are we not HPV infection, which can cause cervical cancer progression? Why are we as a country not prioritizing, or we are doing like the way we did with HIV? We were waiting to start them when they had advanced HIV disease, later to be informed that we can even test and start. And then as we decentralize the treatment, we have this problem of e-waste, in the country. What are we as a program? What are you planning? Because it may also be an associated cause of the cancer. Thank you.
My name is Evelyn from Kenyatta National Hospital. My question goes to the panelists. During the slides or the teachings, we learned that cancer cervix, one, it is coming out that is a sexually transmitted disease. Again, it's coming out that there is an indicator in multiple sexual partners. During my sensitization in the hospital, at the workplace or even in the public domain, we have realized that immediately you talk of sexually transmitted disease. Again, you talk of multiple sexual partners. Do you find any stigma there? What other ones can we use? Just like HIV. This can make most of our patients or our clients not to be screened, especially staff, you. What other ones can we use?
Sorry, the time is not on our side, but let's take those ones. I know the NCI has a lot of them, so let's just move on. But yes, concise.
Well, thank you very much. This has been a very good class, and I think you've been listening, and we do appreciate that an opportunity given to us has actually made a difference in terms of information. Straight to the questions, allow me to appreciate Professor Nduati's questions on healthcare systems in this country. She has raised pertinent issues, and of course, she's been in the system for long to appreciate the gaps which are there. And for sure, human resource in health is a challenge. And it's a challenge that is recognized by this administration and has a clear plan on how to ensure there is equity, there is access of these services across the country. You saw our president launched a human resource advisory, council in health. Pretty much it's to address issues that relates to industrial action, but at the same time, it has a responsibility also to ensure that we have adequate staffing in health with regard to the capacity that we have currently. At the National Cancer Institute of Kenya, to be very specific, capacity building in oncology is one of our mandates, one of our functions. And on Friday and Saturday, it's quite coincidental you are raising this right now, Prof. We are actually having a meeting, 2 days, to discuss differentiation in oncology specialties. And we are not looking at only medical oncology, radiation oncology, clinical oncology, gyne oncology. We are also looking at those who diagnose. Because if we do not diagnose well, then we mislead the treating team. And out of our meeting, it is going to map how many of these qualified, highly trained staff are there. And we recognize that we need to train more. And we are looking and mobilizing resources and advocating for the cost of training to come down so that we can have more of these doctors distributed across our 47 counties. But at the same time, we are leveraging on technology because we appreciate we may not be able to get everyone. And, telemedicine has worked in some areas where if we have most of our pathologies concentrated in urban counties, we have the histotex. Let's talk about diagnosis from pathology and even radiology, where those technicians who are at the centers can take the images if it is radiology, and histotech can do the sectioning and be sent to within this country or even without in that infrastructure, and the report is sent back. This is the only way we can use limited resources to be adequate for all of us. It is something that it has been on trial for the last around 5 years now, and it seems to be working, though it's not adequate. So it's a challenge that we are still working to make sure that is possible, appreciating technology. And digitization, remember, is one of the agenda for this government. And you saw the digital health bill that is under discussion now. And our Ministry of Health, through the sector, there is a lot of push to ensure that every agency or even departments in county governments of health are able to digitize some of their services. Now, in our national cancer control strategy,
If you're taking samples or you're taking photographs of samples and sending them off to be looked at by somebody, who takes responsibility? Who's accountable for the quality of that histology? I have a friend whose child got a round of chemotherapy based on a diagnosis which was then confirmed not to be correct.
well, I know there are legal issues around some of the strategies that we have in place. Our Cancer Prevention and Control Act, the principal act that established NCI, is undergoing amendment, and they are entrenching e-health, because when we have all this, in our law, then the details on who takes responsibility will then be covered, when there is a clear guidance by the law. So we will definitely be informed. We are at the level right now where there is debate in Parliament, and within the next 1 month, this was a private member-sponsored bill, and Governor Wanga was among those who sponsored this bill, and there were 2 other members of National Assembly to amend our act. But there is also now the Digital Health Bill that will be the overall bill that will also address these issues to do with who takes responsibility for what and how. And I want to invite all of us. We have a national cancer control strategy for the sector that details, we have 5 pillars on prevention, early diagnosis, treatment, and research and surveillance are all there. In the UHC content, there is a lot the reason why you are seeing NHIF being, repealed, the act, is because the details, I will only talk about what we desire to see in UHC with regard to cancer, and allow me to defer the details of the fund to NHIF as it is constituted currently, and I'm sure we will get better answers why we are developing 3 different types of funds, because this is a discussion quite advanced, and remember, it is more of an executive decision from the Office of the President, so allow me to defer that to the relevant offices. And I'm sure with due course we will be informed how these 3 funds that are being proposed will work. On the demographics of cancer, Steve from Kisumu region, it is very interesting that from our National Cancer Registry, the NACARE, we are the custodians of all cancer data. Other than the northern part of the Kenya, where the incidences of cervical cancer are low, and it's because definitely they are still quite stringent in terms of their sexual culture, where religion has really controlled their sexual behavior. This cervical cancer is almost equally distributed across the country. But of course, with understanding that HIV is a risk factor, it also aligns to the areas where the prevalence of HIV is higher, which we know the western and Nyanza part of this country, there is more, but it is also influenced a lot by where research has been conducted. There are areas where there is a lot of underreporting because nobody is looking into it. So part of our responsibility, as I mentioned earlier on, is we are charged with this mandate of making sure we conduct research across the country, and that will answer your question. Allow me to also, I want to address all my questions, then I can allow my team to also address what concerns them. Does cancer affect the teeth? More often than not, Esther, you were very keen. The teeth is in the oral cavity. And you've had people who are treated for, a toothache, and for a while, they think it's just a regular, infection. But over time, it is found out that it is more than just the toothache that they had. So there is a lot that relates to also around the oral health and the teeth with regard to cancer. Specifically, it ends up being one cancer called osteogenic sarcoma of the mandible. And remember, the teeth and the mandible, they are all related. It's mainly originating from the bone, and the teeth has bony tissue as well. Turnaround time at KNH. This is a challenge that we have in our country. As it is, we would really wish to appreciate, what we have done to set up regional cancer centers. We have Mombasa working, we have Garissa working. These are comprehensive centers that can provide at least the 3 modalities of cancer treatment: radiotherapy, surgery, and chemotherapy. We have Nakuru, and we have the National Referral Facilities, Moi Teaching and Referral Hospital, we have KNH, we have KUTTRH, and we have those in private sector. As much as unfortunately, how our systems have been designed, there is a lot that NHIF spends in private sector, but we cannot do without them. They are also part of solving our challenges. Now, there is a culture that despite having a center in Garissa, seriously underutilized, people would want to seek care in Nairobi or in Eldoret because they do believe there is better care because they are big cities, which is not true. We've been able to capacitate, a lot of cancer specialists. I was the first formally trained cancer specialist in the western part of the country. Right now, we have more than 15, going to 20. So there is more capacity, and we would want to just encourage our people to make sure they utilize those centers. We are also trying to work through Kenya Health Federation to utilize our underutilized private centers, especially in radiotherapy, so that we decongest our national hospitals. Because you'll find private centers are treating 30 or 20 or 10 patients per day, while in Moi Teaching and Referral Hospital, we have, a waiting time of 3 months. So that one is a work in progress. Just have hope that things will happen soon. On the molecular testing distributed across the counties, we would really, some of these equipment are capital intense, and we encourage the hub and spoke model. We are going to set up regional cancer centers, regional cancer control centers across the counties, so that we can have a comprehensive center around 3, 4, 5 counties, which is well equipped. And using that spoke and hub model, we will educate people to utilize what is available, because we cannot avail this capital intense equipment in all the 47 counties in this country. It won't make sense economically. I hope I've done justice to the questions that required our response. Thank you very much.
Thank you. That lightens the next respondents. Please, we are run out of time. Thanks.
Yes, I'll stick to the medical aspect of things. So I think our friend asked about uncircumcised men and the spread of HIV and HPV. And I do work in Kisumu quite a bit. I go there every once a month, and it has been a major topic amongst the women that I see and trying to urge the men to get circumcised. There have been studies done locally and internationally about the kind of microbiota that are present in uncircumcised male. And so it has been found that for those who are uncircumcised, of course, they will have not only HIV, HPV, but also other sexually transmitted infections like chlamydia and gonorrhea, which worsens the chances of them spreading to their partners. I think Rwanda has done extensive tests, especially or rather studies, and have published on the same, particularly even with men who have sex with men. And it has been shown amongst those particular kind of men, the rates of anal cancer are even higher. So it is something that should be looked at, and we do have the evidence, and it is very imperative for the men to get circumcised for health reasons. Now, the other thing was about the HPV vaccines. Now, I did mention about the Gardasil because that's the ones that's commonly available in the government sector. Gardasil has 2 types, the 4-valent vaccine and the nanovalent vaccine. The quadrivalent vaccine covers type 6 and 11, which we say are benign, and also type 16 and 18, which has been shown by studies in Kenya that at least 95% of cervical cancer in Kenya has been attributed to type 16 and 18. We do have the other high-risk types, especially 31, 33, 52, 58, and so forth, but can be common in other countries and not so much in Kenya. Now, when it comes to Cervarix, it has only 2. It has type 16 and 18. In terms of how it works and how it's given, it's similar for both Cervarix and Gardasil. So for every girl and boy, aged 9 to 15, they can get 2 doses, according to the studies. IV positive or who are immune compromised in any way, that's when it's recommended that they get 3 doses of either Cervarix or Gardasil. So I hope that is clear. So when it comes to women who are more than 15 years, who are already sexually active, they can't still get the vaccine, and even the WHO has approved up to age 45. The reason for this is that as much as you can be covered for, say, type 16, you can get the vaccine and be prevented against type 18. for those who already have an infection, who are not yet exposed to the virus. And that's why we are really trying to capitalize on the age 9 to 15 who are not yet sexually active. HPV test. My dear, you're preaching to the choir. This is a fight that I've had about the cost of HPV. There are some centers where it's 8,600, others it's 3,000. It's ridiculous. It's a life-saving test, and I do not understand why it's still being charged so exorbitantly. And it's a fight that we're having. We're talking to some pharmaceutical companies so that they can reduce the cost, because one of the problems that we have is the reagent that we use to put the brush in to preserve the sample for it to be run through the machine. It's very costly. You can find one of it's called a preserve. It's about 5,700. So that kind of exaggerates the cost for the HPV testing. Others are just malicious. Some people are looking at profit. They're running a business, and they want to charge it expensively, which makes no sense. So please, the more of us that rise up to arms, we will get there. We will get to a point where HPV is free. HIV testing is now free, right? It did not just start like that. It was very expensive when it started. But the more of us who speak, the more of us who argue about this, we will get there. And I have faith that one day we will reach there. And right now, yes, we have all these gene expert machines in the local many county hospitals. It can be used. In my facility, I found a gene expert machine seated there idle because it was not running COVID test. And we repurposed it. And now we started doing HPV test. And there's a study that we're doing currently in MTRH that's also funded by the U54 NIH. And we're running to see the efficacy of the gene expert. And it can be used. So let those machines not go to waste. We can actually utilize them. About the about HPV,
multiple partners, yes,
and multiple partners. This has been a problem, and I have a woman who was a victim of partner violence because of this. But one thing I will say, and I'm sure I'll get a lot of flack out of this, we cannot change the paradigm. We cannot change and lie about what is the cause. People need to understand HPV is sexually transmitted. It's the truth. That's how it works. And people need to understand that's how it gets. And for multiple sexual partners, we have to be clear. It's just not the woman who has multiple sexual partners. It's also the men who have multiple sexual partners. So it's, can I say, blame on both sexes, so it cannot be from one person. And I always tell my women this: if you do test positive for the HPV, it doesn't mean that it's your current partner who's given you or you got it from them. You could have gotten it a year ago or even 20 years ago, because the HPV virus can really persist in the system. So I think the way we try to explain to the women is such that we avoid the blame game. We try and explain as much as it has been, we've gotten the virus, you have tested positive, we can't really know who infected you, when you got infected. And when we talk to the men, I try to explain to them that particularly men can be carriers. It is possible, and it's more common for the man to transmit it to the women. And it's just too common, like if I sneeze at someone and I give them a flu. And so if the people try to understand that, then we can't try and avoid stigma. But I really do stand on this. We really should not change the narrative. It is what it is. It is a sexually transmitted infection. It is a sexually transmitted cancer for 99% of patients. There are women who develop what we call adenocarcinoma of the cervix, which is not related to HPV, and it occurs sporadically. And so there's still that small percentage of women who have probably never had sex, never smoked a day in their life, but they still get cervical cancer. And so it's not something that cuts across the board. I think I got all of them.
Thank you.
Thank you.
Ruth, I think most questions have been answered by Dr. Bailey. All right. Are we going for one dose? I don't know, that's yours, Meli. Let's see it. Go ahead.
Okay. So from data from the Kenshi trial, the Doris trial that's still going on in Tanzania, we have even from Costa Rica, they have shown that the single dose is effective and can last up to 10 years. So as it stands, the Kenyan government has not changed its stance. It still recommends 2 doses minimum, but the world is moving towards the single dose. We are saying that there's still more studies that need to be done, and longer term over longer periods of time just to check on the efficacy. But from the current evidence that we have, the single dose is very efficient. Yeah.
Okay, now this is very sweet and
This is public health. Our coverage of HPV vaccine is very low. If we give one dose and give to the boys free of charge also, you will increase that coverage, because part of that lack of coverage is that there's still the lingering thought that HPV vaccine is sterilizing the girls. And you'll gain much more by doing upfront immunization as opposed to waiting for data whether 10 years from now it will protect you. 10 years from now, you can do a booster.
yes, but I think
And you should
it's a
do the
coverage.
modeling.
Yeah.
Ask them to do the modeling to support that. Yeah.
Okay. Yeah, but the coverage also probably as of now is measured against the girls.
Yes, we are under the Kenya national government, and we have advised them. I know I had a meeting with Mary Nyagasi, and we tried to push this agenda forward. We need all the boys and the girls vaccinated, but there are some issues that have been brought up. Again, the number of vaccines that's available, but we know there's still a lot that has not been given. So I'm hoping with time the government can change the stance. But I totally agree with you. It should be free for boys and girls. In fact, for everyone who can be able to get it.
All right. Good evening, ladies and gentlemen. Sorry. Now we are. I think we looked.
Well, I think it's the centers that I mentioned that have the regional, cancer centers. And I mentioned Mombasa, Uasin Gishu, Nairobi, Nakuru, we have Garissa. And now we are working towards increasing capacity in Kakamega County, Kisumu County, Kisii County, Meru, and Nyeri counties. If you look at these are pretty much the former provincial hospitals to ensure that those becomes the hubs and the spokes will go into the counties around those areas. Yeah.
It has been quite interesting, quite resourceful. I know we can stay here many hours. Thank you so much, the great panelists, Dr. Meli, Dr. Nisa, Ruth, and Zipporah. Thank you for great presentation. They are still available for interactions. You can still interact with them based on their available. Thank you for your patience and for your questions.
Allow me to just invite you to our NCI website for additional information, not on cervical cancer only, but general. And if you do not find any information in our website, you can reach out to the National Cancer Institute of Kenya. At least you'll find a contact in that website where you can do an email or you can do messaging through our website, and we'll be happy to respond. We invite all of you to be our stakeholders. Let's work together in this journey. I'm very happy Zipporah brought in how we navigate our patient care, and not everybody gets an opportunity to get care like Zipporah. Majority of them do not. And we know cost is a limitation, but that is work in progress towards making sure that cancer, if possible, be treated for free just like HIV was. But the cost, of course, has to be taken care by someone. Let's continue this discussion at our respective areas. We are very happy that you had time to spend with us during this session. May God bless you. Know that you are our advocates wherever you be. Thank you very much.
All right, let's appreciate them. Let's appreciate them once more. Thank you so much, and have a good evening. Thank you, team.